Hello everyone. As a part of continuous cardiac education, our topic of discussion today is viability assessment and its clinical implication, which will be presented by Dr. Karthik Natarajan sir, who is associate professor in the Department of Cardiology at Unmicrc Hospital, having more than 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Good morning to all. I am Dr. Karthik, Associate Professor of Cardiology, Unmicrc Institute of Cardiology and Research Center. Today, our topic of discussion would be viability assessment and its clinical implications. So, various organizations define viability in different ways, but simply put, viability refers to a cell that is not irrevocably damaged. In clinical practice and research studies, however, the term is usually applied to areas of the myocardium which show contractile dysfunction at rest and in which contractility is expected to improve after revascularization. So what is the importance of viability? Why do we need viability testing? Ischemic insult remains the major cause of heart failure as a result of loss of myocytes due to myocardial necrosis. Identifying the severity of myocyte loss by non-invasive methods or conversely identifying myocardial viability are useful for decision making and selection of therapeutic strategies for patients with ischemic LV dysfunction. The concept of myocardial viability has evolved from the purpose of myocardial revascularization to myocardial diseases, including valvular heart diseases and non-ischemic cardiomyopathies, where it is used to guide options like CRT, which is cardiac resynchronization therapy, and dedicated electrical interventions. What is the basic pathophysiology? You need to understand the concept of stunning and hibernation. So whenever there is myocardial ischemia, there is an intermittent ischemia with reperfusion relief before necrosis. There is myocardial stunning. In myocardial stunning, there are no histological changes. There is a slightly decreased coronary flow reserve, but the perfusion, the metabolism, the contractile reserve remains normal and there is no scar formation. There is a spontaneous recovery of the dysfunction within days to weeks. But if there are repeated episodes of stunning or there is a chronically decreased blood flow to the myocardium undergoes a metabolic adaptation, which is referred to as hibernation. The basic pathophysiology is that there is dedifferentiation of cardiomyocytes. So what happens is there is a greatly decreased coronary flow reserve. The contractile reserve and the perfusion may be equivocal. The metabolism remains normal and there is no scar formation. All the myocardial viability testing is directed at identifying this hibernating myocardium, because if the hibernating myocardium is identified, revascularization occurs, then there is eventual recovery of dysfunction within weeks to months. Sometimes the dysfunction may not recover completely but improves significantly. But if the hibernating myocardium is not treated or does not undergo revascularization, it undergoes a programmed cell death or apoptosis, resulting in the formation of a myocardial scar. Or if there is very severe and prolonged ischemia, then the myocardium undergoes necrosis. There is very severely reduced coronary flow reserve, the contractile reserve is down, the perfusion is down, the metabolism is affected, and there is formation of a scar, which is practically irreversible dysfunction. This table shows you the evolution from a normal myocardium to a stunned myocardium to a hibernating myocardium to an acute infarct and chronic scar. So histopathologically, you can see the differences from a normal morphology and normal metabolism to contraction, then going towards a stunned myocardium where you have reduced calcium sensitivity of the contractile proteins with intra and extracellular edema, with a dedifferentiation of the cardiomyocytes and hibernating myocardium, with an acute infarct, which is commonly seen in acute coronary syndromes or myocardial infarction STEMI. There is a contraction band necrosis, destruction of the myofibrils and membranes, and there is interstitial edema. And finally, there is the formation of a chronic scar where there is a replacement by fibrotic tissue. The various modalities that we are going to study will give you a better idea. So chronic myocardial dysfunction in CAD may occur due to different conditions. It could be acute ischemia, it could be stunning, hibernation, necrosis and replacement fibrosis, other confounding and coexistent disease like tethering or remodeling, electromechanical dyssynchrony, myocyte loss or dysfunction due to other causes like inflammation and cardiomyopathy. This is a typical figure in which you see what happens when there is an acute myocardial infarction or STEMI. So when you have an occluded vessel, for example, the patient has an anterior wall myocardial infarction, there is occlusion of the LAD. Up to 20 minutes, the area remains at risk. There is no necrosis. There is only stunning and preconditioning. But after 20 minutes to 60 minutes, there is subendocardial necrosis. 60 minutes to 3 hours, there is necrosis which extends into the mid myocardium and subepicardium. And from 3 to 6 hours, you have the completion of a transmural infarction. So ideally, after 6 hours, there is no point in opening up the vessel. So what actually protects the myocardium after 6 hours? So as soon as there is occlusion of a vessel, there are recruitment of certain invisible collaterals, which continue to provide some basal flow to the myocardium. And these invisible collaterals may be enough to sustain the myocardium for weeks to months to years together. And that is why we need to identify this myocardium, which may potentially improve or with the detection of a myocardial viability. These are the consequences of acute ischemia. You can see that there is acute ischemia with a partial or total occlusion giving rise to either a patchy or complete infarction with pre and post conditioning. With chronic repetitive ischemia, what happens is there is initially a chronically stunned myocardium and then it goes to a chronically hibernating myocardium. A hibernating myocardium, although it has metabolic adapted itself, it remains vulnerable to lethal arrhythmias. So how do these various modalities that we study, they'll identify viable myocardium? So one is they will be able to identify electrical activity. Any cell which is viable has electrical activity. So presence of local action potentials, preserved membrane and mitochondrial function, active contraction at rest or presence of contractile reserve, preserved metabolism favoring glucose utilization, absence of myocardial scar or extreme wall thinning or aneurysm. This is the figure which shows you all the possible ways or all the different ways in which the nuclear tracers act. For example, if you take thallium, which is used as a nuclear tracer in Spect scan, thallium is able to enter the cell or cardiomyocyte via sodium potassium ATPase, which is active transport, but thallium can passively redistribute out of the cell. 99 technetium system which has replaced thallium for all practical purposes, is taken up actively inside the cardiomyocyte, and because of its positive charge, it remains confined to the mitochondria and cannot leave the cell. 13 ammonia, which is used as a perfusion tracer in PET scan, can passively diffuse in and out of the cell. 18 FDG, which is a metabolic tracer used in PET scan, is taken up actively by the GLUT1 and 4 transporters into the cell, is converted into 18 FDG glucose phosphate and remains inside the cell. Dobutamine binds to the beta-1 receptors on the cells, activates the cyclic AMP pathway, ultimately resulting in increased calcium release from the sarcoplasmic reticulum. And gadolinium, which is commonly used in LG CMR, is usually confined to the interstitial space. It cannot enter into the cell, and that is why in CMR, the normal tissue appears black, whereas the abnormal tissue, which is basically the interstitial fibrosis or extracellular fibrosis, appears white. So the imaging techniques and their principles to detect viability. So the various techniques will detect any of the following function and stamp the myocardium as being viable or not. For example, if you take thallium, as we studied it detects the membrane function. 99 technetium, it studies the mitochondrial function. Dobutamine echo, it studies the contractile reserve. The PET scan, if combined perfusion as well as metabolic scan, is able to identify the membrane function and metabolic function. And LG, CMR and CT is able to identify scar. These are the various techniques which are used to detect myocardial viability, and the sensitivity, specificity, positive predictive value and negative predictive value are provided. So we move on to the first modality, which is dobutamine stress echo. All of you must be aware of this dobutamine stress echo. We get a basic or a baseline echo done in 3 views, which is a 2-chamber view, a 3-chamber and a 4-chamber view. Then we start dobutamine in a dose of 5 microgram per kg per minute, and at every 3-minute intervals, we increase the dose by 5 microgram per kg per minute, going up to 40 microgram per kg per minute. If at the end of this high dose of dobutamine you don't see an increase in the heart rate, you give the patient atropine to increase the heart rate. So what are the possible 8 responses which you can see in these patients? So if the resting function is normal, with a low dose of dobutamine, the function remains normal, but at peak stress there is hyperkinesia, indicates a normal response. If the resting function is normal, at low dose it remains normal, but at peak stress there is tardokinesis, or it is worse than rest and worse than the adjacent segments, it is known as ischemia, or it is an interpretation of ischemia. If there is the resting function is normal, the low dose it becomes worse, and it is even worse at peak stress. Usually it indicates severe critical ischemia. If there is resting wall motion abnormality, improvement at low dose and worsening at high doses, it suggests biphasic response or a hibernating myocardium. So the idea is you need to identify this myocardium, because then revascularization would benefit such patients. If there is resting wall motion abnormality with improvement at a low dose and sustained improvement, it's a uniphasic response which shows viability without ischemia, either stunning, remodeled segment, myopathic segment, or subendocardial infarct. If there is resting wall motion abnormality, at low dose it becomes worse, and at peak stress becomes even worse, again indicates severe critical ischemia. If there is rest wall motion abnormality with no change at low dose and improved contraction at peak stress, indicates a tethering effect or subendocardial infarct. With resting wall motion abnormality, no change at low dose and no change at peak stress, indicates a non-viable and scar tissue. So this is a typical example of how we do a dobutamine stress echo. The first panel which you see is a normal response. At baseline, the function is normal, there is no RWMA. At a low dose and high dose, there is a significant or gradual stepwise increase in the contractile response, indicating a viable myocardium or normal myocardium. In an ischemic myocardium, what you see is that the function may be normal at rest, but increases at a low dose and then goes down at a high dose. In the third figure, what you actually see is a myocardial contrast. Sometimes it becomes difficult to delineate the endocardial and myocardial borders, and so you need to give some kind of contrast like definitive to actually delineate these borders. And then at baseline, you are able to make out a wall motion abnormality. Wall motion abnormality, and then at high doses, you are able to see that the wall motion abnormality disappears, and there is formation of a or increase in the or a contractile response. In the biphasic response, initially you see that the wall motion abnormality is present. At low doses, there is an improvement in the contractile response, and at high doses, there is again a fall in the contractile, or the wall motion abnormality starts becoming worse. And absent at rest, there is a wall motion abnormality which does not improve with low and high dose, indicates a non-viable myocardium. You will be able to appreciate it better in this slide. So coming to the next modality, which is a Spect MPI. The Spect MPI is the most commonly used nuclear cardiology modality, easily available everywhere. Spect, it utilizes radionuclide tracer to measure the regional tracer concentrations in the myocardium, and can measure viability by determining percentage of peak uptake of the tracer. This can be interpreted with rest images only or with a stress rest testing protocol. The most commonly used tracers are 99 technetium systemib or 201 thallium. So the basic principle of a Spect scan is that once you give the tracer is taken up by the myocardium, it emits photons. These photons, they are captured by a gamma camera. The photons travel through a parallel hole collimator, strike a crystal, and this crystal is able to generate a scintillating event, and it is able to localize from which part of the heart the photons are coming, or the photons have been captured, and this is converted into a light signal, and which gives us the digital images of Spect MPI. This is the interpretation of the Spect MPI. You can see that the topmost view is actually similar to a short axis view of the echo, where you can see the septum, the lateral wall, the inferior wall, and the anterior wall. On the second figure, you can see that it's basically a vertical long axis view, where you can see the anterior, the inferior, and the apex. On the last view, it's a horizontal long axis view, where you can see the septum, the lateral wall, and the apex. These are various characteristics of the myocardial perfusion agents which are used in Spect scan. For all practical purposes, sestamine has replaced thallium. The main reason for this is actually because thallium is generated by a cyclotron and it's not possible to get thallium everywhere. Sestamine is quite easily generated at any site and hence it is widely used. Again, comparison of thallium and technetium. The basic difference is that thallium undergoes a lot of redistribution, whereas technetium does not undergo redistribution. So you require 2 injections of technetium, one at rest and the second at stress. And the amount of radiation exposure is slightly more with technetium as compared to thallium. The major pharmacological agents used for stress testing, the primary agent which we use is adenosine. All the other agents can also be used, but adenosine offers the benefit that you can give it at a dose of 140 microgram for 4 to 6 minutes. It's very rapidly acting and its action disappears within a very short time and it's quite safe. So this is the protocol that we generally use. You can either go for a 1 day or 2 day protocols, rest stress or stress rest. So if you are going for a rest stress protocol, you inject technetium at rest, wait for 30 to 60 minutes, go for a rest imaging, then go for a stress which can be either a pharmacological stress or exercise stress, again inject technetium, wait for 30 to 45 minutes again and then go for stress imaging. So you can do it over 1 day or over 2 days. The same protocol can be done reverse. You give stress, give technetium, within 30 to 45 minutes take a stress image, then review it, then do a rest scan, wait for 30 to 60 minutes and then take rest images. So this is how the reporting of a Spect MPI is done. You have the upper row showing a stress image and lower row showing a rest image in the 3 basic views. The short axis view going from the apex to the base, the horizontal long axis view going from the posterior to the anterior part of the heart, and the vertical long axis view going from septum to lateral. I'll move to some examples. So this is a classical example of a patient who presented to the emergency with atypical chest pain. His ECG was non-diagnostic. He underwent a Spect scan with sestamine and we could see that the short axis view that the anterior and the lateral regions, anterolateral regions in the short axis view, and the vertical long axis view, the apical, and the horizontal long axis view, the apical regions are predominantly affected. And this patient underwent a catheterization on the next day, which showed a tight lesion in the proximal portion of the first diagonal of the LAD. So a Spect scan can also be useful in an emergency department to rule out the cardiac and non-cardiac cause of chest pain. Again, another view in 2 patients in whom there was LAD disease. On the left hand side, you can see that the patient in all the 3 views at rest is showing lack of tracer uptake in the septum, in the anterior wall, in the apex and the atrolateral walls, indicating loss of viability. On the right side, you see that the patient is having good viability at rest in the septum, the anterior wall. Only a small portion of the apex remains non-viable. So according to the scan, the left side patient should be kept on medical management. The right side image patient can undergo revascularization. We move on to PET MPI. Now the main difference between Spect and PET is that PET uses a positron. It relies on detection of 2 high energy gamma photons, and the other basic difference is that it is able to quantify myocardial flow and give us an idea of myocardial metabolism by using a metabolic tracer like 18-FDG. The myocardial perfusion studies can be performed with generator produced rubidium or cyclotron produced ammonia, and the myocardial metabolism is studied using 18-fluorodeoxyglucose. This is how you perform a dual scan with PET. You keep the patient fasting for 6 hours, do a rest scan just like you do a Spect scan, review, then give the patient oral glucose load and IV insulin, and then inject IV 18-fluorodeoxyglucose, wait for 60 minutes and take a scan. So how do you interpret a PET MPI? Very simple. Just remember that whenever there is a mismatch between the findings of the myocardial perfusion and myocardial metabolism, it indicates a viable myocardium. And whenever there is a match between the blood flow and the FDG uptake, it indicates non-viable myocardium. For example, if there is reduced blood flow and there is a preserved or enhanced FDG uptake, indicates perfusion metabolism mismatch. If there is a normal or near normal flow with reduced FGD uptake, indicates a reverse perfusion metabolism mismatch. But if there is a reduced blood flow with reduced FDG uptake or a match, indicates a non-viable myocardium. So this is again a very good example of the mismatch and match. So you can see that the perfusion scan has been done at rest with 82 rubidium, and you have the metabolic scan being done with fluorodeoxyglucose, and you can see in all the three views that there is a mismatch between the short axis view of the perfusion and metabolism. Here you can see that the tracer uptake is absent in the lateral wall, whereas here it is predominantly absent in the septum. In the vertical long axis view, you can see that the inferior wall predominantly lacks tracer uptake, whereas here the apical regions lack a tracer uptake. In the horizontal long axis view, the lateral portion lacks tracer uptake, whereas in the metabolism part, the septum lacks tracer uptake. So this is a mismatch indicating a viable myocardium. Whereas if you see the lower image, there is a typical match between the perfusion scan and the metabolic scan, indicating that this is predominantly a non-viable territory. So CMR again it allows comprehensive assessment of patients with CAD, helps us in identifying myocardial wall thickness, regional function, global function. The principal method of assessing viability by CMR is detection of scar and scar extent by LGE. Dobutamine stress CMR may be complementary for improved accuracy when LGE predicts the probability of recovery to be indeterminate. And now you have the T1 mapping techniques, which have also demonstrated promise with further confirmation studies which are awaited. LGE used with CMR has become the reference standard for the non-invasive imaging of myocardial scar and focal fibrosis in both ischemic heart disease and non-ischemic cardiomyopathy. Wherever available, I think CMR has replaced all the other modalities for initial screening for viability. Clinically used, as I already told you, gadolinium, when it is injected, you take the scan within 10 to 15 minutes. It is confined to the extracellular space and the normal tissue appears black, whereas the abnormal tissue with fibrosis or scar appears bright. Again, this is a typical example of the function and the LGE. You can see that as the normal appearing tissue appears black, indicates that there is absence of a scar, and as we move downwards, you can see that there is the black portion, normal tissue starts disappearing, and you have a completely white region indicating that there is a transmural scar in this case. Dobutamine stress CMR can be used at low doses to evaluate the contractile reserve. An infusion of low dose dobutamine induces systolic wall thickening in viable regions of the myocardium, but not in irreversibly scarred areas. And if it can be elicited, usually the myocardium is more likely to improve after revascularization. So by using LGE CMR along with dobutamine CMR has now become the gold standard for initial screening of patients for viability. The newer non-contrast imaging techniques have come, like T1 and T2 magnetization recovery times, as well as computation of the extracellular volume, and other spectroscopic methods like evaluation of myocardial 23 sodium concentration as a marker of membrane function, and myocardial 31 phosphate creatinine ratio to ATP ratio to evaluate myocardial energy homeostasis. So after looking at all these modalities and confusing ourselves, which modality and when? This is the question we have to ask ourselves. Is there a gold standard? No, there is no clinical gold standard for viability testing. In direct comparison, stress echo and stress CMR have higher specificity, and Spect, PET and LG CMR have higher sensitivity, and there is no definite cutoff value for any of these viability studies. So these are strengths and weaknesses of all the imaging modalities depending upon the availability, the cost, the operator dependence, the radiation exposure, the spatial resolution, the duration of examination, contraindications. So what I'd like to tell you is that the viability scan should be dependent on the institute where you practice. I think every institute has its own viability test in which they have perfected themselves, where CMR is easily available. I think that should be the gold standard, but where CMR or PET is not available, I think Spect done properly can be the best imaging modality or viability testing modality. So now I'll come to some examples where you have a discrepancy between two scans, showing that none of the scans is actually confirmative or definitive. So here was a patient in whom on the left side you can see that this is a Spect scan. So in the Spect scan you can see that the inferior wall, the apex, is showing a non-viable territory depending upon the Spect scan done at rest. But when an LG CMR was done, there was absence of a scar. This patient was having very severe LV dysfunction on echo and having triple vessel disease. So he was initially referred to us for viability. We did a Spect scan, found to be non-viable, but this patient underwent a CMR and was found to have viability, underwent CABG and was doing well. This is another example. You can see that the patient is having very severe triple vessel disease. When the echo was done at baseline with low dose and high dose dobutamine, you can see that it is showing an absent response. There is a wall motion abnormality at rest, and with low dose and high dose dobutamine, there is no improvement, there is no increase in wall thickness, there is no improvement in the wall motion abnormality, indicating non-viability. But when you do a PET scan, you can see that most of the apical, the anterior regions are viable. It is only some part of the inferior and the lateral regions are non-viable, which constitutes a very small amount of myocardium. So this patient also underwent CABG and did well. So it is not always that echo or dobutamine stress echo may be the best modality. Sometimes you may need to confirm viability with 2 or more different modalities. Again, this is an example of a patient in whom there was an LAD CTO and critical disease of the OM. He underwent a dobutamine stress echo. You can see that the EF is 20%. The patient was advised medical management on the basis of a DSC. But when you go for a CMR, you can find that actually there is no scar whatsoever and this patient can undergo revascularization. What are the clinical implications of viability testing? Why do we want to do all these things? Why do we have to break our head? So the idea is that if you find myocardium to be viable, the patient undergoes revascularization, the ultimate aim is that there is improvement in the regional and global cardiac systolic function. There is an improvement in the left ventricular volume and LV reverse remodeling. There is improvement in the patient's functional status and heart failure symptoms, and there is improvement of survival. So the next question you may ask me is that, is this supported with data? So I may advise a CMR and get the patient's CABG done, but is it supported by any clinical evidence? Unfortunately, although there have been multiple randomized, non-randomized studies which have demonstrated that viability-guided revascularization may help in short and long term, there is no large-scale randomized trial which has shown the same. The largest study to date remains the Stitch trial. I'll throw some light on the Stitch trial. So the Stitch trial was basically the trial in which around 1,200 patients were incorporated. And out of that, 601 patients, they underwent viability. Now the viability testing modality used in Stitch was 3/4 of the patient, they underwent a Spect scan with thallium or systemi B, and around 150 patients, they underwent, 1/4 underwent viability testing with DSC. Out of that, 487 patients were found to be viable, 114 were found not to be viable, and then 243 patients underwent medical treatment in the viable arm, 244 patients underwent CABG in the myocardial viable arm. In those patients who did not have viability, 60 patients were put on medical management, 54 patients were underwent CABG. So this was the result. So you can see that if the myocardium is not viable and you put the patient on medical therapy, the mortality was 56%. But if you put the patient or the patient undergoes CABG, the mortality is 42%. Whereas if the patient is having viability and you put the patient on medical management, the mortality is 35%. And if the patient undergoes CABG, the mortality is 31%. So the Stitch trial actually does not help us much. So irrespective of viability, CABG is showing a non-statistically significant improvement as compared to medical management. But what is the limitation of this trial? First of all, only 600 patients out of the 1,200 patients underwent viability testing. So there was a lot of selection bias. Plus the patients who were included in the viability arm, they had higher MI prevalence, lower angina symptoms, lower EF and more advanced LV remodeling. In fact, the LV end diastolic volume in these patients who were actually found to be viable was more than 120. So even other studies have shown that with this advanced LV remodeling, even if you have viability, even if you have some symptoms of ischemia, the overall prognosis remains very poor with revascularization. So the selection of patients was not proper. The definition of viability was broad, resulting in 81% of the total study population considered to have viability. Neither PET nor CMR was chosen in the study. Medical therapies including SGLT2 inhibitors and ARNI was not included. So coming to the end, what is the clinical utility of viability testing? We as interventional cardiologists come across angiograms, we come across patients, we come across varied symptoms. So where do we use this viability testing? So there is no international protocol to use a viability testing. You have various specific indications. So guiding the revascularization of patients with heart failure, known CAD and wall motion abnormalities. This has been given a class of recommendation 2B and level of evidence B by the ESC. Guiding the revascularization of patients with heart failure and a late presentation of ACS. To select the optimal revascularization strategy in patients with complex multivessel coronary disease. Depending upon PCI or medical therapy in patients with CTOs. Determining the mechanism of MR and guiding the decision for valve replacement and revascularization in patients with ischemic MR. Determining the contractile response, low dose Dobutamine echo and low flow aortic stenosis. To identify scar imaging and distinguish between ischemic and non-ischemic myocardial damage. And CMR to optimize lead positioning for CRT and to allow non-invasive substrate identification and electrophysiologic planning of VT ablation, which has been not given any current level of recommendation. So in the end, I'll just show you a few examples of where viability testing has helped us. So the topmost slide is a patient who presented with anterior wall myocardial infarction and critical LAD stenosis. You have done a baseline CMR. There is no scar on with LGE testing, and this patient underwent a PCI to the LAD, and 4 months later, you can see that the LV has become totally normal. Then on the lower image, you can see that this is a patient who is having triple vessel disease with an MI around 2 months back. The baseline angiogram shows that there is a large scar in the anterior, the apical and the anterolateral territories. This patient, although he underwent a CABG, 7 months post revasc, you can see that the dysfunction still persists. Again, this is a very interesting case where the patient was a 75-year-old female who presented with acute heart failure. The troponin is positive. The ECG is showing Q waves in V1 to V3, indicating an old anterior wall myocardial infarction. The echo was, her EF was very much down, around 20-25%, with an akinetic anterolateral anteroseptal anterior territory, the LAD territory was totally gone. We did a cath of this patient, and I'm not sure whether you can see it clearly, but the patient had a focal stenosis of the circumflex and the RCA, and there was a diffuse disease of the whole LAD. So here the question was whether we needed to do a PCI of the circumflex and RCA only and leave the LAD alone, because on the basis of an ECG and transthoracic echo, we thought that the LAD would be non-viable. Or we go for full revascularization by CABG. So when a CMR was done, there was no scar in the LAD territory. So this patient underwent a CABG and did well. This is a very common indication and very interesting indication to us interventional cardiologists, because we come across CTO day-to-day in our day-to-day practice. So this patient had an old inferior wall MI, there is mild inferior wall hypokinesia, and the RCA is totally occluded. The patient underwent a Spect scan, in which you can see that at rest there is a normal tracer uptake in the inferior territory and there is mild stress-induced ischemia in the inferior wall. So the patient underwent a successful CTO recanalization, and post CTO you can see that there is a normal that the inferior wall hypokinesia is gone and the patient is doing well. This is again a good case. This patient underwent a PCI to the circumflex for an inferior wall MI and had moderate to severe MR at that time. But post PCI, the patient got admitted twice or thrice with severe MR with symptoms of heart failure. You can see that there is very severe MR, grade 3 with a ERO of 56. He underwent a viability evaluation, and you can see that there is a scar which is close to this posteromedial papillary muscle, and he underwent an MV repair, and at 1 year follow-up there is no MR whatsoever, and the patient did not have any further hospitalizations. This is the typical example where we commonly do viability testing. You get a baseline echo where you have a gradient which is not so high, a peak gradient of 45 with an AVA or aortic valve area of 1 centimeter square with severe LV dysfunction. The coronary angiogram shows a non-obstructive CAD. You go for a Dobutamine stress echo at baseline with 10 microgram, 20 and 30 micrograms. You can see that there is a gradual increase in the gradient with an improvement in the EF indicating a good contractile reserve and an AVA which still remains less than 0.6 or still remains less than 1 centimeter square, indicating that it's a low flow situation, low flow, low gradient, severe aortic stenosis. The CMR was done which showed a normal, there was no scar, no transmural infarction. The patient underwent AVR and did well on 1 year follow-up. The final example where decision making is very useful in CRT, this patient was a post-COBG patient 10 years back with well-functioning grafts but having very severe LV dysfunction. The ECG says to of a left bundle branch block. And this is an integration of the CMR with the coronary sinus anatomy. And generally it is said that where you have a scar, the LV lead should be placed away from it. So you can see on the CMR that the scar is close to this inferior wall and the posterolateral wall is free of a scar. So we implanted the lead directly to the viable myocardium, and post this CRT implantation, the patient's QRS became quite narrow and the patients who had to be admitted recurrently with heart failure did not require any further hospitalization. So at the end, the take-home messages are only two, that it may help in selection of patients and guide further management, but a careful integration of clinical, anatomic and functional information regarding ischemia and viability from non-invasive testing is necessary to individualize difficult management decisions based on the best available evidence and sound clinical judgment. Thank you.